Good afternoon, everybody. We'll give 1 minute for some folks to get into the webinar and then get started. Good afternoon, everybody. My name is Frank Harrington. I'm the Director of Reimbursement and Regulatory Affairs for the American Association of Nurse Practitioners. I just wanted to really thank everybody for attending this webinar today with our colleagues at CMS on the Making Care Primary Model, co-hosted with our colleagues at the American Nurses Association and American Academy of Physician Associates. We really appreciate you all taking time out of your busy days. We know it can be difficult to attend a webinar when you have clinical practice. So we really appreciate your time and really want to give a big thanks to the team over at CMS for all the work that they've done in developing these models, considering stakeholder feedback, and then coming to help educate our members and inform them about the model opportunities. Speaking for AANP, I can say that it's a huge priority of ours to make sure that our members are participating in and informed on value-based care models and the different opportunities available to them. So we're really excited for this presentation today so that you all can learn more about the Making Care Primary Model and hear what it could do for your practices. Before I kick it over to the CMS team, I just want to turn to my colleagues, Trevor Simon and Jonah Mainzer at the other associations to say a few words on their behalf.
Hi, Frank. Thank you. I definitely want to echo what Frank said. We want to thank CMS for being here today and speaking to all of us about the MCP model. We believe that PAs and NPs and nurses can and already do play an important role in these models. We've heard some robust interest in the promise of these models as PAs learn more and more about them. But we look forward to working with CMS to ensure that this model is well known and can be a success, and providing our perspectives when the agency would find it valuable. Jonah?
Hi, good morning, good afternoon, everybody. I just wanted to welcome everybody to the webinar. Also wanted to thank CMS for putting together the presentation, and let's get started.
I would just like to throw in one housekeeping item before we get started. There is a Q&A function at the bottom of your screen. There's CMS staff on the call. So if you have any questions, please put them into the Q&A, and we'll also be doing a Q&A at the end of the presentation.
All right. Thanks, Frank. Should we go ahead and get started with the presentation?
Yes, please do.
Sounds good. I'm going to turn it over to Nicholas Minter to kick us off.
Yeah, thank you so much. It's a pleasure to talk to you all today. First off, I'll just acknowledge I'm getting over a slight cold myself, so I've been in need of primary care recently. So my voice is a little scratchy, but I'm really happy to be here and to use it in support of talking about how CMS, with your help, hope to improve primary care in the future. So why don't we jump into it? Next slide. So really quickly today, we'll go over several things. First off, we're saying hello now. We'll go over what Making Care Primary is, how it is relevant to you all as advanced practitioners and PAs, and sort of where CMS sees primary care going in the future with your help, and how we're planning to support it above and beyond what you all have experienced today. We will leave ample time for question and answer. And then, of course, we will leave you all with some resources that will be made available to you all after the webinar as well. So, don't worry about jotting everything down. Next slide. As you probably have confirmed really quickly, I'm Nicholas Minter. I'll start off the presentation talking a little bit about the overview of Making Care Primary, and then I'll pass it off to my colleague, Lauren McDevitt, who will talk a little bit more about what CMS in Medicare fee-for-service is going to change for our participants to better support their move into more robust, team-based, and patient-first primary care. Next slide. So, first off, I want to start at the beginning. Why does CMS and Medicare want to test a model to promote better, more robust, and more accountable to patients' primary care? Well, the reason is simple, and I probably don't need to tell you all this, but for a long time, primary care has been an undervalued and undercompensated specialty. It's a specialty that, frankly speaking, can single-handedly drive health equity, that's incredibly responsible for driving better quality outcomes, as well as controlling cost of care and keeping people out of the hospital. And yet, we have seen primary care complexity, the number of specialists that primary care has to coordinate with, the number of patients that primary care clinicians and other providers see has gone up over time. And all of that is true before the public health emergency of 2020 and so forth. And so, we think that it is imperative to move primary care off the hamster wheel of fee-for-service and to better support it so that it is able to do more for the patients that it sees and to be compensated more for the value that it brings the primary care, the health spectrum through primary care. So what we'll talk about today is a 10.5-year model that builds upon lessons learned that CMS has garnered from prior models that we've tested since 2020 and officially since 2012 when we launched our first primary care transformation model. We have learned that we need to invest more in primary care. We need to give that investment time to grow and to yield. And so we're testing this over 10 years, which is unprecedented for a model coming out of the CMS Innovation Center. We know that we need to focus on quality improvement and help practices change their current workflows to be more inclusive, to do more, and then to make that something that's routine as opposed to a constant learning process. So we're bringing resources to the fore to do that. And we also know that we need to provide, again, more support, both in terms of learning, data, and finances to better integrate both behavioral and specialty care. And so we'll talk about how we're going to do that. But we think through doing that, we will hit many of the goals you see here in the boxes. We'll provide more comprehensive primary care. We want a patient to be able to come to the primary care office and get their needs met, both within the four walls of that practice, as well as to be linked to the care that they need in the community. They need mental health services to have those resources. And if they need to be, care managed outside the office, that those resources are funded and supported by that primary care office. And we know that, again, we have to step up to do that. We want to be able to make a path or to provide a pathway to value-based care that is funding primary care prospectively for the patients that you serve, so that you don't feel like you need to see 30 to 50 patients a day, but that you can see those who are sick because you're getting paid to manage all of your patients up front on a quarterly basis. And so we'll talk about how we go from where we are to there. And we think that this is important to start on and to focus on, especially for those small, rural, independent, and safety net practices that haven't had a viable pathway away from fee-for-service before. And we think by doing that, we can better focus on improving quality and, over time, reducing costs, which is at the heart of what Congress has asked CMS through the Innovation Center to do. Next slide. So first off, who does the model target? Once we get into the nitty-gritty here, the model is really targeting those primary care organizations participating at the 10 level that provide primary care services either through Medicare, they're billing the physician fee schedule for those that sort of follow that terminology, or they are, as you see here, an IHS practice, certain critical access hospitals, or in particular, federally qualified health centers are also eligible. When we say primary care organization, we don't just mean that they have to only provide primary care, but that is a core part of their business. So multi-specialty clinics, to be very clear, nurse practitioner-led clinics, are all eligible if they provide a predominant amount of their services or a majority of their services, or even a significant minority that fits sort of what we consider to be primary care services. As you see here, even health systems can apply, and we will enroll only their primary care clinicians. So that's who is eligible. Who is ineligible to apply, as you see here, rural health clinics are paid differently, and we are looking at sort of finding opportunities for them outside of making care primary, so they're not eligible to apply. Concierge practices that charge a monthly rate are not eligible. Importantly, those practices already in an existing CMMI model, which includes those practices currently in primary care first, ACO REACH, they are also not eligible to apply or participate in the model. Importantly, if your practice or those that you know, your organizations are participating in the Medicare Shared Savings Program, you are eligible to apply, but will need to decide to disenroll from MSSP before 2025 in order to join Making Care Primary for the next decade. So we can talk more about this later, but I want to keep going in the interest of time. So perhaps the most important innovation that we see in Making Care Primary is, unlike prior models like Primary Care First, which was targeting advanced primary care practices ready to take on limited downside risk for increased upside and patient accountability, or even CBC Plus, which we tested many years ago, which started with a couple of different tracks that didn't necessarily progress over time. We want Making Care Primary to be a comprehensive on-ramp for primary care organizations, no matter where they are, in terms of complexity or familiarity with alternative payment models, to be able to go from not knowing anything to thriving in value-based payment and patient-first care. And we are doing that by designing a 3-track model that increases progressively in terms of care delivery requirements, in terms of moving away from fee-for-service, but that allows practices to tell us where they are in terms of readiness to move away from fee-for-service and into value-based payment, and then allows them to progress over time. So what you see here are 3 tracks. The first track is intended to help build infrastructure. It includes, as Lauren will go over in more detail later, a significant increased payment above what they're receiving currently in fee-for-service to help them make investments that will pay for needed infrastructure, needed staffing, help them learn, along with resources that we will provide, how to sort of construct new workflows to risk stratify their patients, to care manage more appropriately, and to really improve literacy within their own patient population, to empower patients to start better managing themselves. After 2 to 2.5 years of time, practices in track 1 will move into track 2, where they continue to receive an above fee-for-service payment per member per month for every Medicare patient they care for. And in addition, we will convert half of their fee-for-service income to a prospective population-based payment. That way they are able to get used to, on a gradual basis, caring for their patients on a population level. So they see those who are sick and not necessarily all of the patients that they normally see because they need to bill for them. You see who you need to see. You manage your population based on who needs your care the most. We will also focus on more advanced care delivery requirements, and for the first time, pay considerably more based on quality outcomes that the practice is able to produce. Moving on into track 3, we will convert that fee-for-service payment I've been referencing fully to a prospective-based payment, so that you're getting all of your revenue that you were getting before the model up front and are able to manage care according to that, to that budget, and see the patients again that need your care the most, and not just everyone to keep the claims running. We will pay increasingly more for performance and a little less in terms of upfront payment, but there still will be an above fee-for-service guaranteed payment. Important to note before we go on, this model is all upside. We don't think primary care is at a place where we can ask it to potentially take less than they're earning now in order to do more, or to put them at risk for performance in a downside manner. What we are offering is the opportunity for primary care gradually to become more autonomous, less reliant on billing claims, and to get paid more for the results that we know that primary care can produce. Next slide. So here is just a summary list of what we think, CMS thinks, are the benefits of joining the Medicare Making Care Primary model. The first is, as I said, we will shift away from fee-for-service. There's no downside adjustment. It's all upside. One thing that I haven't mentioned quite as much is for those practices that are the most behind, if you will, the curve in terms of transitioning away from fee-for-service, we offer an upfront infrastructure payment that will help in a lump sum manner catch those practices up with their peers and give them infrastructure money to make significant investments in HIT, in staffing, in bringing on e-consulting platforms, if that's what's needed to really be able to move into a value-based payment environment in a successful, sustainable way. As you see here, we're not just offering more money, we are also offering better data on the patients that you see. Medicare will set up a data dashboard that provides access to claims data that informs you of what your patients are doing when they're not in your office. We think that'll be really critical to improving care. We will better collect or better connect you to what's going on in specialty offices, both in terms of integration and data. And we will also create more tools to help you understand how to meet the model's goals and also how to be more aware of what's going on in terms of interacting with health information exchanges. We have a real health equity focus in this model. We will have waivers in the model that allow practices to waive copays for those patients that you care for that sometimes don't go to the office because it's too expensive. We want to make sure we're also focusing on creating robust connections and supporting you all in connecting with community-based organizations to address those community needs that can't be fixed inside an examination room. And we want to improve the way that we identify health-related social needs, and we'll provide instruction to practices on how to do that better. And then finally, we are setting up a learning infrastructure that builds upon the work that you all are doing now to increase your learning, but also focuses on allowing practices in the model to talk to each other, to understand what each other is doing and learn from that sort of intra-model spread of ideas and lessons learned, and also to sort of work with other payers and practices and to learn best practices from the field in a way that is productive and directly connects to how you are paid for increasing performance. Next slide. So really quickly, where are we testing this model? As you may have heard back in June, we are testing this model in a limited corridor of states because we are making significant investments in primary care. So we chose 8 states based on several factors. Number one, we think this is characteristic in general, or as best we can, of the rest of the nation. So if it's successful, we plan to expand this model to other states. Also, we have already begun working with state Medicaid agencies to align with where they see primary care going in the future. We know that we can't do this alone. We'll talk more about this in a second. And so we know that we need to work with Medicaid first and foremost to decrease the amount of payer fragmentation and make it easier for you all as providers to take on this new set of requirements and responsibilities without it seeming like more work. We want you to focus on the patients and not the requirements. So the 8 states you see here, I won't go through all of them here, but we'll just note New York is a little bit different in that we are only testing in New York in the upstate region. That is every county above Westchester, not including the city of Long Island. So again, we think we've got a really robust collection of states. We're already working with payers, state Medicaid agencies in those states, and are excited for what's to come. Next slide. So a little bit more about what it means to be aligning with payers. As I said, our premise is simple. Medicare is a big payer. We know that we matter, but we're not the whole enchilada. We're not the whole game in town. So if we really want to cause practice transformation, if we want to create that, if we want to drive that forward, we have to work with the Blues plans in your state. We have to work with Medicaid. We have to work with the other national and regional payers so that on the areas that create fragmentation for providers, we're creating alignment instead. And so we've come up with a payer partnership strategy that makes sure that we're working closely with payers to align on the things that make participation in the model for you all easier. That includes making sure that we are moving payment away from fee-for-service for primary care. If you receive all of your funding up front, it's a lot easier to manage a population than if you're only receiving Medicare funding up front. We want to make sure that where we're measuring similar quality outcomes, we're doing so the same way, so that you have, as much as is feasible, one definition of success, so you can really focus on those quality measures and those outcomes. Eventually, we want to provide data across all payers that looks the same. It has the same data elements. And eventually, throughout the 10-year model, we want to reach a point where you can go to one portal or one health aggregator, data aggregator, and receive all of your data across all payers in the model. So you don't have to memorize 7, 8, 10 different portal IDs. You get everything you need from one portal, because we know that's the key to really unlocking provider potential and using this data effectively. And then finally, we want to make sure that we're working with providers to have a learning strategy, or payers and providers, to devise a learning strategy that doesn't just add a whole bunch more events to your calendar, but really aligns across all of our partners to create a robust and distinctive set of events throughout the year that help you achieve success in the model, and therefore higher payment and value for the value that you give us in the healthcare spectrum. So again, we are working with Medicaid, we are working with other payers, be that Medicare Advantage, commercial, what have you, and are really focused on being able to provide to you all a clear picture of all of the payers, I should say, that we're working with by early next year, when practices are determining whether or not they want to participate for the next decade with us in this model. Next slide. So really quickly on the timeline, just to be very clear in terms of when you all will know more about what we're doing with payers and a little bit about the practice deadlines. We are talking to payers currently. We've been talking to Medicaid for many months. They are in the midst of designing their approaches that will align with MCP. We are currently talking with the big regional payers currently, and by January, February of next year, we'll be able to share with providers exactly who is aligned with CMS in the model, who has made the commitment to lessen the burden of participation in this model in each region. So for you all, the dates that you need to remember is applications are due. You'll see this again, but by November 30th of this year, applications are non-binding. By the end of February, you will have gotten an acceptance packet from us that tells you a number of things. It tells you how many patients would be attributed to you in the model, whether or not you're eligible, as well as what payers are participating in the region. And as you see here, going forward through 2024 and 2025, we will get more data from payers on how they're going to align, and then we will nail that down and provide you more of that detail as well. Again, the model begins technically in July 1st of 2024. You'll get more of this detail later, but just want to note some of these dates are far enough out that it gives payers time to align, but it also gives you all time to really experience the benefits of alignment, as this model is 10 years and won't end until 2034. Next slide. So that's the conclusion of sort of the overview of Making Care Primary. It's my pleasure to relinquish control of the microphone, so to speak, and hand it over to Lauren to talk to you more about what Medicare is doing specifically to make primary care better. Thank you.
Yeah, thank you, Nick. And so great to be here with you all today. Thank you for taking the time out of your busy schedules to learn more about the Making Care Primary model opportunity. So I'm going to build on what Nick already shared about, our overall goals by walking you through some specific design elements of the Making Care Primary model that will impact kind of the way that we pay primary care from the Medicare perspective. And I know Nick just shared more about how we're planning to align with other payers. So this will be kind of a good perspective of what Medicare payment and Medicare requirements will look like in this model. And then I want to spend a little time talking about next steps for submitting an application before we get to your questions, which we're really excited to get to. So moving forward. So the model will have several care delivery requirements that teams need to meet as part of participation. That is really part of the overall vision of the kind of holistic, patient-centered care that you all want to provide in your daily jobs. So we organize these requirements into domains of care management, care integration, and community connection. I'll spend just a moment talking about each of those. So in the care management domain, you will provide typical kind of care management, care coordination services, and that will grow from each track, from track 1, where you may be building initial infrastructure to do risk stratification, into track 3, where you'd be optimizing those workflows for patients who can benefit the most from those services. Care integration will be more around integrating with behavioral health and providing and making sure behavioral health needs are met by patients. So starting with screening, but also then working to build capabilities to really address those needs within the practice, or connecting them to folks who can meet their needs. And we'll also be providing a real emphasis on specialty care integration. So supporting primary care participants with better tools to engage specialists, which I'll walk through more in a few slides. And then finally, in the community connection domain, we really do believe that it's critical to improved outcomes to address the spectrum of all patients' needs. And so in the community connection domain, we'll be encouraging participants to partner with community organizations, bring on community health workers and other staff to the team to address the spectrum of patients' needs. Within this kind of care delivery requirements and structure, we will also have a health equity plan component to care delivery, where CMS will look forward to hearing from you all on your goals for improving health equity in populations, and working with you to kind of hone those strategies as well, kind of as part of this care model that we'll be testing. Now, all of this care will be supported by payment tools that are not necessarily or are not available in fee-for-service. And so while, on the last slide, you may look at those care delivery domains and requirements and think that those are things that you all are already doing, which is great. We want to support that. We want to better support that with payment. And so some of these payments Nick already started to talk through, but I'll go through them a little bit more here. So the first is really key, is that you'll start to receive your primary care payment upfront. And so that should give you flexibility to provide care in a team-based manner and in a manner that is really according to patient needs, not so much billing. You will also receive payment above fee-for-service in the form of enhanced services payments. And those are on a per beneficiary per month basis. And they're also adjusted by both clinical and social risk. So that way, patients who are more complex will receive more payment for the more complex patients. And again, this is on top of the typical payment you would receive in fee-for-service. Those payments from the enhanced service payment are, as Nick mentioned, the highest in track 1. So it's a significant investment for those who are new to value-based care in track 1. But those payments do remain in tracks 2 and 3, just to a slightly lesser extent, as the improved bonus potential, improves and increases. One thing to just mention about these enhanced services payments is that they do replace care management or CCM billing, as well as a few other services that are kind of considered duplicative of this payment. However, we hope that paying this payment upfront will give you all more flexibility to be able to deliver services without needing to bill or meet those billing requirements for the CCM services. Another part that's important to kind of round out the core payments for your primary care organization would be the performance incentive payment. And so that is really the quality bonus component of the model, which relies on the quality measures that I will show. I think they're on the next slide. So the performance incentive payment is what accounts for your performance on select quality and cost and utilization measures. So we'll be providing your primary care payment, increasingly upfront depending on which track you're in. We'll be providing the enhanced services payment on top of that to support your care delivery transformation. And then the care delivery transformation and activities that you do, the theory is that will lead to improved outcomes. And so the performance incentive payment is where you are rewarded for those outcomes. And so I'll walk through the quality measures in just a moment here, but this performance incentive payment starts out as a relatively low percentage of your revenue in track 1, while you're receiving higher enhanced services payments. But in tracks 2 and track 3, the upside grows exponentially. And so participants who are performing well can expect to be rewarded for their performance and the care delivery transformation that they are undertaking to better serve patients. And the second kind of row of these payments, I do want to walk through a few of these. So the upfront infrastructure payment is a kind of one-time in payment, although it's broken up into 2 installments for those organizations that are brand new to value-based care that also meet additional criteria listed in the request for applications. And that upfront infrastructure payment is meant to support more of the kind of hard infrastructure costs. So IT, some staffing costs, and we have kind of allowed uses of the upfront infrastructure payment also listed in the request for applications. And so this is really intended to remove any barriers that organizations may have into engaging in value-based care. It's not intended for those who have prior experience, but the upfront infrastructure payment will be available. It's $145,000. It's available to those who are eligible, and it is not a loan. It is not something that we will be required to be paid back. There are some stipulations to that. So if an organization receives the upfront infrastructure payment and then they withdraw from the model before they enter track 3, then we would require it to be paid back. And of course, if there are other kind of compliance issues, then we may require it to be paid back, but it is not a loan. So of course, CMS will make sure that that payment is spent appropriately through kind of spend plan reporting and reporting, but we do just want to make sure that you all know that that's not a loan, and if it's spent in accordance with our rules, it's not something that will need to be paid back. The last 2 payments are to better support specialty care integration between primary care and specialists. So the first is a new kind of fee-for-service payment in the form of the MCP e-consult code, or MEC. And so that code will be a new payment that is available to primary care participants to bill with more flexibility than the existing e-consult codes in the physician fee schedule. So you'll be able to be paid more easily for your collaboration with specialists. And additionally, something new that we're introducing is actually a billing opportunity for select specialty care partners that you may want to partner with in your organization to better serve your patients. And so by a specialist identified by you meeting the requirements of what we call a collaborative care arrangement, So you would be in the driver's seat of making sure both selecting the specialist for this component, as well as being in charge of determining whether that specialist is meeting your needs and whether or not you want to continue to have them listed as a specialty care partner with CMS. But if they are meeting all of your needs and have been identified by you, they will get an opportunity to bill a new code, the ambulatory co-management code, and that'll be available only to Track 3 specialists who are partnered with Track 3 participants, but this is meant to really support that specialty care integration. So there's a lot of payments in this model, and I will just say that these are detailed in more detail in the request for applications, which is available on our website, which I think Frank put into the chat earlier. So I will move us forward, but hopefully that was an okay overview, and happy to walk through any other questions. So this slide really tries to take everything that was in the last slide and boil it down to what it will look like most likely from a core primary care revenue standpoint. And so as we've discussed, in Track 1, you do stay in fee-for-service for your primary care payment, but you're getting significant enhanced investment on top of fee-for-service to drive transformation. The bonus is a little smaller, but that does increase in Track 2 and then even more in Track 3, the potential. Of course, dependent on performance, but the potential is much higher. And we do phase in more prospective primary care payment in between Tracks 2 and 3. So we move to 50% prospective primary care payment in Track 2 and 100% prospective primary care payment in Track 3. I think, yes, the other piece just to mention here is that I think I mentioned that the enhanced investments are highest in Track 1, but they do phase down, but are still present in all 3 tracks, which I think is important to note. And I think Nick mentioned this earlier, but just to reemphasize it, that this is an upside only model. There is no kind of financial risk as part of this model. So on to quality measures. We have identified a list of really kind of key primary care measures or core primary care measures that are present in all 3 tracks. But as tracks progress, we do add measures to reflect the growing kind of care delivery capabilities and expectations and advancement that we expect to see in the model. So we start out with just some core ECQMs or electronic clinical quality measures for controlling high blood pressure, diabetes, and colorectal cancer screening, as well as a measure of patient experience. And then as we progress into Tracks 2 and 3, we add measures that really get at how well are you meeting the behavioral health needs of your patients, as well as kind of screening for their health adjacent needs that may be more social in nature. And of course, we are also interested in seeing, reduced unnecessary cost, as well as unnecessary utilization, like ED visits, and also a total per capita cost measure, which is a measure of Part A and B spending. And something that we're also interested in looking at is how do participants individually improve on these cost measures? So, for example, the total per capita cost measure will be also looking at including a measure of continuous improvement that looks at your own historic TPCC score, as well as your current score, and looking at kind of improvements between those kind of benchmarks. For FQHCs, so if you work at an FQHC or a site that qualifies as an Indian health program, EDU continuous improvement will be what we look at. And another important thing to note is just that kind of as a baseline, participants will need to exceed the 30th percentile on the TPCC measure to be eligible for the performance incentive payment. And that will be looking at, a benchmark that includes both MCP participants and those who are not benefiting from all of the enhanced learning and support of the model. All right, moving on from measures. I know I touched on this a little bit in the payment slide, but it is worth dwelling on that we know that primary care cannot do this alone. And so they really do need the engagement of specialists, and we recognize that can be a challenge. And so we are committed to providing our participants with both the financial tools that we've discussed, but also data from specialists in their region, and really focusing on having our MCP participants partner with cardiology, pulmonology, and orthopedics in areas where we've identified that maybe utilization could be a little bit better controlled. Again, with learning tools and peer-to-peer learning, we expect to kind of foster an environment where participants can share their best practices in engaging with specialists. And CMS is really interested in learning more and hearing from our participants on how engaging specialists is going. And since I already walked through the payment components of this, I do think I will move on. And so another key area that I think we've touched on a bit previously in this presentation is how important health equity is to achieving the goals that we have set out, both as just the broader CMS and the broader health industry, but also MCP. And so, as mentioned, there will be a requirement for participants to develop a health equity plan, and that's really just kind of specifying a population that the participants really want to focus on and improve disparities around. And CMS will partner with you all to kind of review that and optimize that plan. We're also, as mentioned, those enhanced services payments that we're paying on top of the core primary care payment that you're receiving will be adjusted by clinical and social risk factors. That way, our resources are resources provided are proportional to both the clinical and social risk of the patients you're caring for, so you can meet their more complex needs. There will, of course, be health-related social needs screening, as well as that quality measure of screening for social drivers of health that we walked through on the last slide. We're also providing an opportunity for participants to kind of reduce or waive the cost sharing that would typically be part of billing patients. Participants will not have to bill patients if they don't want to, and if they are for select services, of course, and you'll have to kind of notify CMS that you're going to be doing that. But we hope that will also help folks with their implementation of their health equity plans as well. And CMS will also collect data to better understand and evaluate health disparities in our MCP communities. So I know that was a lot. This is a 10.5-year model, and we have bold goals, and we're really excited to partner with primary cares and their communities to kind of bring this model to your communities and to meet those goals. So our immediate next steps are we're soliciting applications. And so if you are interested in joining the model, this is the opportunity. This is the only cohort that we are planning for participating in the model. The model is planned to begin on July 1st, 2024. So if you're interested in participating, do submit an application by November 30th. If we haven't already, we can get you all the links to that and the website. You can also reach us by reaching out to our email address at mcp@cms.hhs.gov. I think Nick already walked through the payer partner recruitment timeline, so I think I will leave it there, and I think we're going to move over to questions. So Frank, I think I'll turn it over to you.
Absolutely. And thank you so much, Lauren, Nicholas, and everyone at CMS for this presentation. And also for the folks on the call, as I mentioned at the beginning, this will be recorded. We'll be sending this out and posting this after the meeting. So, and promoting that up until the application period is closed. So please feel free to send this recording out to your colleagues who think would be interested, but didn't have an opportunity to participate today. So Lauren, we do have some questions we received before the meeting, and for anyone else who has additional questions, please keep putting them in the Q&A. And if we can't get to them, but during this presentation, we'll make sure to follow up afterwards. So the first question we received is, can a new NP-owned primary care practice with less than 50 traditional Medicare beneficiaries participate in the program?
Yeah, thanks for that question. So we do encourage folks to start an application. So CMS can provide just the best support once we have your information. And so we do have the requirement that 125 Medicare beneficiaries be attributed kind of over the most recent kind of 4 quarters of the model to be eligible. But of course, we do want to encourage new practices to be able to join. So I'll just say that we really do kind of encourage you to apply. The 125 beneficiary requirement is important for making sure we're paying and doing quality measurement accurately. But that said, like, we do want to be supportive and understand that some organizations are new. And so we definitely don't want that to be a barrier for you submitting an application.
Thank you. Really appreciate that answer. We also received some questions about practices that are participating in other models. So if you are participating in the GUIDE model or ACO REACH, can you also participate in MCP?
So great question, and it does depend on which model it is. So I'll actually take ACO REACH first. So ACO REACH, we are not allowing those who were participating in ACO REACH in 2023 to apply. We do not want to pull from existing models that are being actively evaluated for this cohort. So we appreciate that may be frustrating, but we are not able to accept applications from those who were in ACO REACH for 2023. Now for GUIDE, GUIDE is allowing overlap with ACO programs and MCP. So GUIDE actually is planning to overlap with all models and really to nest kind of intentionally within other models. And I will have to defer more details for the GUIDE team, kind of when they're coming out with more details about their model with the request for applications. They're planning to share more details about what that will look like if, say, a GUIDE participant is also an MCP participant, what that will mean for kind of adjusting payments and things like that. But there will be allowed for kind of concurrent participation in MCP for GUIDE and MCP, recognizing there's some orgs that are eligible for MCP that are not eligible for GUIDE, but we won't get into that right now.
Thank you very much. And I know we see our greatest participation of NPs in the value-based care program, I think, as most folks do, in the Medicare Shared Savings Program. So would you also speak to overlap in MSSP?
Yeah, also a great question. So we will allow applications from those who have been in MSSP. And so, if you were in MSSP last year, if you're in MSSP this year, if you're planning to be in MSSP for 2024, you can still apply to join the Making Care Primary model. You would still start the model on July 1st, 2024, if you were on, say, an MSSP ACO's participant provider list for 2024. You'll still start MCP in July 1st, 2024. You'll still do, onboarding and your initial reporting. But you will not receive any payment until 1/1/25 when you've been removed from that MSSP ACO's roster. That way, we don't have any duplicate payments or shared savings payments for our models there.
Great. Thank you very much. And I'll pass my colleague Trevor for some additional questions.
Hi, thank you. So the next question we received is, what care delivery transformations have been successful in other models, and how have they been incorporated into MCP?
Yeah, that's a great question. I'll take that one. So when we talk about other models, I mean, we have been testing primary care transformation work really since 2012 in the Comprehensive Primary Care Initiative. And what we learned through that model, CPC Plus after it, and are learning through the testing of primary care first, is that practices are really effective if given proper authority, agency, training and financial support in improving in care managing their patients. So care management is one of our domains, as you saw, for care delivery. And we have seen and continue to iterate upon helping practices risk stratify their patients if they aren't, and then determining which of those patients and how best to care manage those that need it, be that through longitudinal care management, through episodic care management, and also, again, to improve health literacy for management of chronic conditions. Our evaluations of prior models have shown repeatedly, and literature has certainly supported, that over time, practices can change the way that they manage their patients if given those resources, and that will lead to better quality outcomes. The second area that I would note is a hallmark of our work, and that we have tested for nearly a decade and are building upon with this model, is behavioral health integration. It is not effective if a primary care practice is unable to address mental health services when a patient enters the office. They're less likely to go somewhere else. They go to the primary care doctor to hopefully get most of their issues dealt with, or to get a referral to one place, not several places. And so we have focused on behavioral health integration and are doubling down on that in this model. We want to make sure that practices understand care management in that first domain well. So we are really focusing on behavioral health integration in track 2, and we'll, again, provide additional resources to support that and reward practices for the progress that they show integrating that workflow. We are building upon that with specialty integration. And again, what we have found is the more central that we can make you all as providers and the physicians that you work with in primary care, the better patient outcomes are going to be. The primary care practice needs to be at the center of the work. And so in doing that, we believe we are building upon lessons learned of what can be effective in past models. And again, focusing on things that we know are more relevant today, or at least more recognized as necessary to good patient care, like building out those community-based organizations. Thank you.
Great, thank you. Our next question is, as these models are not intended to be static, how can participants provide feedback regarding potential modifications? Are there opportunities to partner to provide the PA/NP nursing perspective when future iterations of the model are being developed?
Yeah, I can take that question. We intend for this model, it's a decade long. Healthcare today looks different than it did 10 years ago. And likewise, we anticipate that this model and the way that it supports primary care will evolve. It certainly won't lessen. If anything, it will need to be more robust over time. But again, if you look 10 years ago, we wouldn't have predicted a pandemic. We wouldn't have predicted the proliferation of specialists or many of the trends that you all are well aware of over those last 10 years. So again, we are always open for feedback in how we administer the model, the policies that are in place to support nurse practitioners and primary care and physicians assistants, as well as primary care organizations in general. And we have planned to review the model iteratively over the next decade, and are very open to implementing new policy to implement, be that new payments, be that new agency for primary care to do more than it does today, so that you all are on the front line, able and effective to respond to the healthcare needs of tomorrow. So what we would say is, if you're a participant in the model, you'll be able to reach out to us directly. We will have avenues for that. Please continue to work through your associations, which have been so kind as to host this webinar today. We talk to them on a regular basis. And, continue to sort of think about what you all need and let us know. This is a partnership. Our model succeeds if you do. So to be very clear, we're excited about what the future holds, and we are ready to evolve over the next decade alongside the care that you are going to provide to your patients. Thank you.
Thank you. Will there be a common coordinated set of quality metrics?
Yeah, sorry, I wanted to make sure I wasn't still on mute. So yes, as Lauren covered, we have a set of quality measures that builds upon what CMS is calling the universal foundations, which means that it will be a quality measure set that exists across many CMS programs. As I know I mentioned during the payer partnership section, we are working to align where other payers are measuring, controlling blood pressure, to make sure we're doing it the same way, to make sure our diabetic outcomes align, so that, again, you all have one outcome to focus on and one definition of success. I will note, we're not telling Medicaid that they can't measure things that are important for their populations. So if they're our payer partner, they're still going to measure things like vaccine uptake in pediatrics. That's important, and Medicare doesn't have a lot of peds. However, we want to make sure that we do, over time, reach a common core quality measure set, so there's not payer fragmentation around what we're asking you all to do, and that you all have one set of goals as far as it goes, along with MCP. This is hard, and change doesn't happen overnight, but it is something we're committed to, because, again, we know we can't do it alone, and we know that if we create more complexity, it doesn't make things easier for you all, and that is not our goal. Thank you.
Thank you so much. I'll now turn over to Jonah to ask a few more questions.
Hey, thank you for all your answers. We also received a number of questions about payment. Could you please provide examples of how the upfront infrastructure payments may be utilized?
Yeah, thank you for that question. So I'm happy to provide some examples. I'll also start off by saying that participants can use those funds within kind of 3 specified categories. Those are kind of increased staffing, as well as social determinants of health strategies, and then healthcare infrastructure. And so some examples of those, for example, kind of in each category, an example of increased staffing would be hiring a nurse care management or other nurse care manager or other relevant support staff, hiring community health workers, peer recovery specialists, etc. There are a lot more examples in the RFA. The second category would be social determinants of health strategies. So you could develop or secure transportation services or housing related services to address housing insecurity. Those are some examples of those. And then the third is healthcare infrastructure. So, investments in electronic health record upgrades or expansions, e-consult technology investments, connections to clinical data registries, etc. And I know that these are really broad categories, and it does feel just useful to say that as part of kind of getting the upfront infrastructure payment, you'll submit kind of a spend plan to CMS, letting us know how you plan to spend it. We'll check and make sure that fits within our categories. And then we will, assuming everything looks good, you'll receive the first installment, and then you'll report back to us on how you used it. So, those categories I walked through and some of the examples I walked through are meant to be instructive, but they are also are broad and meant to be flexible. And of course, we'll review the participant reported spend plans as part of that as well.
Thank you for that. The next question we received is, how does a practice transition between the different tracks? Will there be a technical support available for practices as they progress through the model tracks?
Yeah, great question. So transitioning through the tracks actually will be kind of automatic. It will be something that happens after kind of the time in track is done. And so for if you started in track 1 or you're starting track, regardless of track 1 or track 2 or 3s, you're going to be in an extra kind of half year in your first track. So for track, if you started in track 1, you'll transition to track 2 after 2.5 years. And so that will be something that kind of everyone in the track moves up at the same time. And so, of course, there will be technical support provided to participants, not just during track transitions, but throughout the model, both to help people understand the policies, but also kind of learning supports and to make sure that folks know how to be successful, not just to understand the policies. So we do anticipate, of course, that since everyone will be moving up at the same time, that it will make sense for CMS to provide, maybe more targeted resources around moving up in tracks around that time. But also want to emphasize that, support will be available throughout the model, regardless of that being a time when you're transitioning tracks.
Thank you. We also have another question. From the practice standpoint, how will multi-plan Medicaid alignment be operationalized? What will need to be in place for a practice to ensure that their participation is aligned across all participating payers?
I'll take that one. It's a great question. And, so really we are working with payers directly to align on MCP. In essence, our goal is to align in the background with them so that they redesign, their current, their next agreements with practices in managed care, that they, sort of realign what they're offering going forward, so that when it's time for you all to sign it, to reconstitute your contracts with them, they align with MCP, which is a long way of saying, we don't want you to really have to do anything other than to evaluate what's brought to you all and to sign the contracts, knowing that it makes your sort of quality management plan, your, quality improvement strategies easier over time. Again, we're working with Medicaid, we're working with private payers. And from your standpoint, we want you to apply to the model by November 30th. We want you to look at, sort of your eligibility when we return that back to you all, and then to begin making more for the care that we know and the value that we know that you provide to your patients. There should be a lot of extra effort on the multi-payer alignment front, because that's the work we're engaging in, and it should sort of yield fruit, if you will, for you all without a lot of additional effort. Obviously, you all will have individual negotiations in terms of the practice itself with those payers, because they are coming up with their own aligned approaches. But our goal is for it to just make sense, to simplify what you all have to track and report on, so that it makes sense for you all to participate in this model and their aligned plans. I hope that's helpful. Thank you.
Thank you for everything. And with that, I will turn it back over to Frank.
Thank you very much, everyone. And that is all the time that we have for questions today. I want to give just another huge shout out to the CMS team, Nicholas and Lauren for the presentation, Jade, Liz, for fielding all the questions in the chat, and everyone else at CMS, and the ANA and AAPA for putting together this webinar. We'll be following up with additional materials. As I mentioned, this presentation will be made available after the presentation. So please share that widely. We'll be promoting it until the application period is closed. So please feel free to forward to any of your colleagues who think would be interested in the model. And with that, I hope everyone has a wonderful afternoon and take care.